Everyone, welcome to Retina Imaging Conference. My name is Atos Halabati. I'm one of the research fellows at Retina Service, and I'll be presenting today's cases. Starting with our first case, 46-year-old male presents for evaluation of blurry vision in both eyes. Dr. Sivalingam, would you please walk us through these images?
Yeah, happy to. So we have a wide field pseudocolor image of the right eye. Visual acuity significantly decreased at 2400. Media overall looks clear. Looking at the disc itself, this looks very abnormal. Hard to, there's kind of this elevated kind of gelatinous appearance to the nerve. Certainly can't really see a normal cup here. And it kind of has this grayish, just kind of diffuse grayish appearance with these kind of scattered punctate hypopigmented lesions throughout. I don't see any hemorrhages themselves, and you can make out the margin itself. So hard to say if this is disc edema or disc drusen or some type of melanocytoma of the optic nerve. Looking at the vasculature, looks normal, and then looking at the macula itself, there's this large mixed hypopigmented scar involving most of the macula. Centrally here, hard to say if this is kind of prominent choroidal vasculature due to severe retinal thinning or if this is hemorrhage. And then kind of surrounding the border of this central scar, this looks like pretty significant retinal thinning. You can see the choroidal vasculature coming through. And then here in the temporal mid-periphery, there's this kind of jagged, linear, hyperpigmented lesion with kind of a halo of hypopigmentation surrounding it. And going back to the peripapillary area, similar findings here as well, superiorly and inferiorly as well. It's rather subtle, but when you see this in the temporal periphery, you want to check the nerve as well. And then there's some kind of small pigmented scar here. The rest of the visualized periphery looks normal.
Excellent.
And then here we have same imaging modality. In the left eye, visual acuity is 2200. A lot going on here as well. Media is clear. Similar appearance to the optic nerve. There's this kind of diffuse grayish appearance. Hard to say on this photo if it's elevated or not. And then, we see these kind of punctate hypopigmented lesions overlying the nerve as well. And then similar findings here. We see these kind of linear streak-like lesions radializing off of the optic nerve, extending out to the periphery. Looking at the macula, there's this large area of what looks like retinal atrophy with kind of pigmentary changes throughout. We skipped the vasculature. So vasculature overall looks normal. And then going back to the periphery, so temporally similar to the other eye, we see this kind of jagged linear lesion, streak-like lesion here. And then actually here, surgical history is important, but this almost looks like the ridge of a scleral buckle. You can see some chorioretinal scars, supratemporally, possibly a cryo or laser scar. Similar findings here and frotemporally as well. So fundus autofluorescence of the right eye. This tells us a lot about what was, possibly going on in the optic nerve. Strong hyper autofluorescent signal coming from that area. So the first thing I think of is disc drusen or some type of calcific process. And then looking at the macula, that area, that large chorioretinal scar, we see a large area of hypo autofluorescence with surrounding kind of speckled hyper autofluorescence correlating to that area of thinning. The periphery has a normal autofluorescent pattern. Oh, actually, so going back to those, let's look at those areas where we saw those streaks. It's hard to say if this is a vessel or if that correlates to that streak that we saw coming off of the optic nerve. You definitely see hints of it here as well. So there's hypoautofluorescent signal correlating to those linear lesions that we saw. And then it's a little bit more subtle here, but that temporal area, I think that's a hint of it here as well.
Yes, another thing that can cause hyperautofluorescence is dehemoglobinization of blood, and it can occur. It doesn't happen late. It's when the heme separates from the hemosiderin, you can get a hyperautofluorescent signal.
Thank you.
And then similar findings here. So strong hyperautofluorescent signal overlying the nerve. This demonstrates nicely this kind of linear streak-like pattern of hypoautofluorescence correlating to those streaks that we saw on the color fundus photo. Interestingly, here there's kind of this halo of hyperautofluorescence surrounding. And then looking at the macula, again, a large area of hypoautofluorescence with a ring of speckled hyper signal here. And then looking at those areas of the scars, inferiorly, we see this increased signal down here. Again, you can see the buccal ridge here as well. And then, another linear hypo signal correlating to one of those streaks out here in the nasal periphery. IVFA of the right eye, we're at 29 seconds. Looks like we're in venous laminar phase here. So a lot going on. So looking at those streak-like areas, we see kind of early hyperfluorescence. Something this early, likely you think of window defect, but we watch how those behave in later frames. And then looking at the macula itself, these darker areas here, I correlate to those areas of atrophy. If we remember the color fundus photo, there was those kind of denser areas of pigment. So, this could be kind of blockage from those dense collections of pigment. And then we see the choroidal vasculature really coming through, likely due to the severe retinal thinning. And then kind of a border of hyperfluorescence. We should watch these areas to see how they behave in the later frames. And then 1 minute, 24 seconds, full AV phase. So persistent hypo signal correlating to this dense pigment changes, but this area, go back to the earlier frame. Yeah, so if you watch this and then go forward, there's increased hyperfluorescent signal here. Possibly, I think you can potentially call that leakage or staining. And then these areas have increasing hyperfluorescence as well. Persistent hyperfluorescent signal in those linear streak-like areas as well. And then, later frame here at almost 5 minutes, increasing hyperfluorescent signal in the inferior macula here, and then kind of coursing up to the superior macula as well.
Left eye.
Yeah, so left eye, we're at 1 minute and 56 seconds. Again, you see this hyperfluorescent signal correlating to those streaks. This really nicely highlights the streaks coming off of the nerve and in the periphery as well. And then looking at the macula itself, again, you can see kind of the choroidal vasculature coming through, but I don't see any obvious areas of leakage here. We'd have to look at the later frames to confirm. Yeah, just looks like atrophy to me. Yeah, and similar findings at 5 minutes.
Excellent.
Okay, great. So this is a horizontal and vertical cut in the macula of the right eye. So we can start with the vertical, looking at the infrared image here. We see these dense diffuse pigmentary changes in the macula. Looking at the B scan itself, vitreous looks clear. Hard to say for sure if the hyaloid is down. It looks like it might be. There's kind of a subtle hint of it here. And then going layer by layer. So relatively well preserved, nerve fiber layer, internuclear, interplexiform, but then we see this large cystic area centrally with disruption of the outer retinal layers here. So if we follow this, this is a large area of hyperreflective lesion in the outer retina. Significant loss of the outer retinal layers, ellipsoid and photoreceptor layers here. We have this large area of increased transmission, likely due to the significant thinning here. And then choroid looks pretty thin here as well. The choriocapillaris is fairly thin. And then looking at the horizontal cut, similar findings, kind of, cystic changes centrally, and there's kind of this broad base, hyper-reflective, looks like some type of possibly fibrovascular complex here. I think we're kind of just above or maybe over that area that was lighting up on the FA. And then again, this really highlights how thin the choroid is here. And you really get this increased transmission through this area of thinning here. So, you can see the photoreceptors, the ellipsoid zone is kind of abruptly stopping here, and we get significant loss of those layers.
I'll show an OCTA image of the disc.
Yeah, so this is helpful. Obviously, you have to be really careful with the segmentation. But it looks like there's possibly, so this is, going right through that area that was pretty suspicious, showing some hyperfluorescent signal. This does look like possibly there's some flow signal going through that area that looked like a fibrovascular complex. So I'd be worried about some type of vascular activity here. Hard to say for sure if this whole thing is a vascular net, because we were seeing a lot of clumpy pigmentary changes here, but it'd certainly be suspicious, especially with the overlying fluid. You can get kind of like an ex vacuo type of effect where you get these cystic changes. But, seeing the flow signal here would make me suspicious of something truly active. And then here we have the left eye. Similar findings, but not as severe. So, there's a nice, well-preserved, vitreous is clear. There's some opacities here. I don't see the hyaloid down for sure. And then the inner retinal layers look fairly well-preserved. But then looking at the outer retinal layer, so looking at the outer nuclear layer, we see these kind of small cystic changes. And then, again, similar to the right eye, we see significant loss of the outer retina photoreceptors here. This is interesting. This is kind of almost like a gap in the RPE itself here. The RPE layer kind of just stops. And then again, the choroid is very, very thin throughout. So, he could be myopic, or this could be due to some ongoing chronic process here. And then looking at the horizontal cut, similar findings. You can see some elevation. So if we track this here, this looks like RPE. There's possibly some type of sub-RPE complex here. But the photoreceptors, there's diffuse loss here. This almost looks like maybe a pigment clump here. And then again, thin choroid. Yeah, so this B scans can be really helpful when you're trying to figure out what's going on with the optic nerve. I think this kind of just confirms what we were thinking. So we have this is a B scan slicing right through the optic nerve. You can see this kind of focal dome-shaped hyperechoic signal overlying the nerve with posterior shadowing. So again, likely disc drusen. versus some type of calcific process. And then same findings here. It's elevated, it's hyperechoic with a
Thank you.
hypoechoic signal behind it.
What would be your differentials at this point for this patient?
Yeah, so this patient has a lot going on. So we have bilateral, central, chorioretinal scars with thinning, some cystic changes on the OCT, some, hints of, vascular activity in the right eye. So, thinking of things that cause CNV, you can think of AMD, myopic degeneration. It'd be unusual to have this bilaterally, but you always want to think of some type of trauma. And then kind of old infectious processes like congenital toxoplasmosis. But then, not forgetting those streaks, those radial streaks that we saw bilaterally as well. You want to think of, lacquer cracks that you see in pathological myopia, as well as angioid streaks. So you can think of, the Pepsi-Ham differential for angioid streaks. Those would be the main things. And then with the disc drusen, in order to put that all together, I know in some forms of pseudoxanthoma elasticum, you can see prominent disc drusen as well. I think those would be the main things I would be worried about.
Thank you. You almost got most of the things that we were thinking of. Lacquer cracks, angioid streaks, AMD, trauma, corridor rupture, toxoplasmosis, histoplasmosis, chronic CSR, and macular dystrophies. So I'll provide some more history. As you described, this patient had a history of RD in the past and underwent scleral buckle at Wills Eye Hospital. And the family history was non-contributory. The patient was Caucasian and didn't have any history of smoking and alcohol use. So what would you want to know at this point in terms of physical exam and history?
Yeah, so if we're worried about, different connective tissue disorders and things on the angioid streaks differential, so you want to ask about any hematologic disorders, any family history. I guess we got that. There's no significant family history. And then, basic physical exam. So you want to look at the skin and the nails. You can ask about any cardiac history, any dermatologic history, if they've, ever had a skin biopsy. And then, general history, any trauma, any prior injections. I think that, the history of myopia is important. But yeah, those would be the main things I'd be thinking about.
Excellent. This is the picture of patient's neck, but our patient denies prior dermatological biopsy or cardiac evaluation. So what would be your next step at this point?
Yeah, I think, you could go a few different ways. I think it's reasonable because if you have access to it in your clinic to administer genetic testing. And then most importantly, if we're really suspicious for, angioid streaks and possibly pseudoxanthoma elasticum, especially based on the skin findings, you want to get this patient tied in with a primary care doctor who can really coordinate their systemic workup. So, getting them to a cardiologist, a dermatologist, to get a diagnosis if he already does not have one, because you want to rule out all the things that are dangerous and life-threatening, like the cardiac complications that can come with those disorders.
Excellent. Our patient underwent genetic testing and ABCC C6 mutation was found in our patient, which is classic for pseudoxanthoma elasticum. So our diagnosis, as you mentioned, was pseudoxanthoma elasticum. This disease causes mineralization of elastic fibers in many tissues and accumulation of calcium and other minerals. The main pathology is the decreased level of inorganic pyrophosphates, which is basically as anti-mineralization factor, and it causes fragmentation of elastin-containing fibers in connective tissues, but primarily in mid-laminar layer of dermis, Brooks membrane, and mid-sized arteries. Patients In patients with pseudoxanthoma elasticum, most common problems arise in skin, eyes, blood vessels with premature atherosclerosis, and gastrointestinal tract and CNS system. It is caused by autosomal recessive mutation in ABCC6 gene in the short arm of chromosome 16. So ABCC6 gene is an ATP-binding cassette transporter protein. When ABCC gene is mutated, ATP in extracellular space decreases, which causes decrease in the level of pyrophosphate, inorganic pyrophosphate, and this causes ectopic mineralization of different parts of the body. So in terms of ocular findings, we have code orange, which is diffuse mottling of the RP in temporal mid-periphery and is not associated with vision loss. You can see here the code orange appearance of the macula. And also we have angiodystrix, which is basically cracks in the Brooks membrane that radiate from optic nerve. And the reason is mineralization of elastic fibers, loss of elasticity, and enhanced calcification in Brooks membrane. Other ocular findings are CMV, dystrophies like pattern dystrophy, drusen of optic nerve, and peripheral comet tail lesions, subretinal fibrosis, and blue sclera. Speaking of optic disc drusen in pseudoxanthoma elasticum, because we saw this finding in our patients, there was a study in 2019 coming from France, and they evaluated 155 eyes with pseudoxanthoma elasticum, and they reported prevalence of optic disc drusen to be 24% in these eyes. No evidence of significant link between optic disc drusen and other fundus abnormalities was found, and these optic disc drusens more commonly located in nasal sector of the optic nerve, and they never involve central vision. So if a patient with pseudoxanthoma elasticum comes with complaint in central visual acuity, we should always evaluate the macula instead of optic disc. So as you can see here in our patients, optic disc drusens are located in nasal sector of the optic disc, as was described in the previous paper. So comet tail lesions appear as hyperfluorescence spot with their tail toward the optic disc. These are chororetinal atrophies and are unique findings for pseudoxanthoma elasticum and may be pathognomonic for this disease. And the famous Pepsi ham mnemonic for angiodystrix, as Dr. Sivalingam mentioned, pseudoxanthoma elasticum, Paget disease, sickle cell, idiopathic homocystinuria, acromegaly, and Marfan syndrome are the reasons for angiodystrix. In terms of management, we started anti-VEGF treatment for our patients because of concerns for presence of CMVM in the right eye. Amslegrid was prescribed to monitor the central vision, and our patient was recommended to follow up with PCP to cardiology evaluation to rule out aortic and cardiac involvement. So there is a study published in Graphics about aflibercept for CMV secondary to pseudoxanthoma elasticum, a prospective study. Patients were evaluated for about 1 year, and 15 patients with CMV were involved in this study. And BCVA improved from 75 letters to 79 letters, which was not statistically significant compared to baseline visit. And the mean number of injections in this study was 6.7. And 5 participants had persistent or reactivated CMV activity at final visit. In terms of management in these patients, cosmetic surgery can be helpful to remove excessive skin, and lifestyle change can limit cardiovascular symptoms. NSAIDs should be avoided to decrease the GI bleeding risk, and dietary restriction of calcium has shown no benefit in these patients. And also our patients should avoid contact sports or very rigid protective, eye protective to prevent choroidal rupture. And here you can see Karim Abdul-Jabbar wearing eye goggles, not to prevent choroidal rupture, but it was a corneal abrasion in NCAA game, which led to wearing eye goggles for the rest of his career. So moving to our second case.
Question for the attendings before we move on. So in these cases of CNVM and pseudoxanthoma elasticum, do you typically treat like you do in like a myopic CNV where you treat if you see fluid, but then you don't really have to kind of treat and extend? Or do you do, something more similar to AMD, where you kind of slowly treat and extend them?
I don't have too much experience, but typically I treat it like myopic degeneration, treat and extend, and then if they reactivate, you come back to it. It's not like AMD that are every 4 weeks or every 8 weeks.
Thanks. A 27-year-old man presents for evaluation of decreased vision in the left eye. Our patient states seeing flashes and floater in the left eye, and trace vitreous cells was observed in both eyes. Dr. Shahlai, would you please walk us through these cases?
Happy to. So we have a pseudocolor wide field fundus photo of the right eye. Central acuity is intact. Media grossly appears clear. It sounds like there may have been some trace cells. Looking at the disc itself, the nasal aspect appears slightly obscured. The temporal part looks okay. No hemorrhages there, and retinal vasculature appeared to be of normal contour and caliber extending to the visualized periphery as far as I can see here. No lesions in the macula. Just looking at the retinal pigmentation itself, there is this subtle hypopigmentation perivascularly just along the superior arcade. Hard to tell if that's actually real versus just the appearance of the nerve fiber layer on the pseudocolor, and the retinal periphery appears grossly intact here. Same imaging modality of the left eye. Once again, vitreous grossly clear, but trace cell as noted before. Here we see more of a blurring of the disc margin, almost 360 here. And once again, these perivascular, maybe even here, periarterial hypopigmentary change along the superior arcade, supratemporal arcade. And more prominently, we can see this distinct appearing geographic lesion in the central macula, well-defined edges here, maybe even emanating around the disc as well. And in terms of the retinal periphery, mid-periphery appears pretty intact. I don't see anywhere else of any pure vascular or perivascular involvement or hemorrhage.
Here is a more zoomed-in view.
And here we can nicely see, first of all, that pigmentary change does appear to be around an arterial here. Again, if it's real, not nerve fiber layer changes. And then you can kind of see this very distinct appearing geographic confluent lesion here, just emanating from the temporal aspect of the disc and involving most of the central macula.
Excellent.
Wide field fundus autofluorescence of the right eye. And then our attention is drawn to these hyper autofluorescent changes. Again, here superiorly around the supratemporal arcade, kind of a little more diffuse and widespread than what we were seeing on the color photos, and also here inferiorly as well. More of a speckled appearance with these kind of distinct foci that we're seeing inferiorly. And interestingly, also in the mid-periphery, we do see some autofluorescence changes in the form of these speckled granular appearance in the mid-periphery, mostly temporal and nasal. Don't see much of it superior and inferior, but some of that may be blocked. And same imaging modality of the left eye. More distinctly, we can see this hyperfluorescence pattern of the posterior pole. It corresponds to that central lesion we were seeing on the color photos, but it does actually go past the arcades, both superiorly and inferiorly, and almost has this peripapillary appearance to it, as well as involving the central macula. In addition, we are also seeing those similar, almost granular appearing changes in the mid-periphery, once again, temporally and also nasally as well. And we have a wide field intravenous fluorescein angiogram. We're at 56 seconds. The veins appear to be fully filled at this point, maybe some laminar flow present here, but our attention is drawn to similar areas of pathology we were noting on the previous imaging modalities, with distinct hyperfluorescence contributing to those changes we were noting earlier. Again, along the supratemporal arcades around that area and also inferiorly as well. So early hyperfluorescence there as well. Also these kind of granular speckled appearances here in the nasal, in the temporal periphery as well. So at this point, they're either window defect or staining, and we'll see how they evolve as we move along. And then at 1 minute, 7 seconds, kind of similar appearance of the hyperfluorescence patterns in that similar sectoral distribution that we see here, as well as maybe some increase in this granular appearance of hyperfluorescence. Seems to be more than one could just attribute to microaneurysms. They don't all seem to be respecting the vasculature, so I think there's a little more than just vascular change going on here. And here at 2 minute 51 seconds, we see it's pretty widespread, actually almost involving the entire fundus. These small specks of hyperfluorescence involving the entirety of the fundus, almost to the extent that we can visualize, and persistent staining of this more intense hyperfluorescence that we can see around the disc here, superiorly and inferiorly. And then once again, just persistent staining. I don't really appreciate much in terms of leakage. Around the disc, there is some hyperfluorescence, so maybe a little bit of disc staining happening late as well, kind of corresponding to that little bit of swelling that we could see on the clinical photos. Excellent. And then the same imaging modality, this time the left, I'm assuming the transit was on this side. We have an earlier frame at this point. We can see the laminar flow in the veins at this point in time, which is appropriate. And then once again, we're seeing this hyper fluorescent pattern corresponding to the areas of change we were noting previously. So mostly central macula, but it does extend beyond the arcades superiorly and also inferiorly. And a hint of those changes, those speckled changes we were seeing in the temporal periphery, even nasally early on as well. And at 46 seconds, we have full venous flow at this point. Once again, very diffuse, widespread punctate changes we're seeing on the fluorescence patterns, and the central macula more predominantly involved here. Some staining we have going on. And at 1 minute, 20 seconds, maybe some extension of the hyperfluorescence. I don't see any frank leakage, so mostly staining at this point, and similar diffuse changes as we were seeing before. And at 3 minute 50 seconds, we actually might have some leakage happening here in the temporal macula, some extension of that hyperfluorescence, so suggesting maybe some microvascular leakage. The disc appears a little hot and stained at this point in time. And once again, the diffuse widespread punctate fluorescent changes.
JP, is the staining of the optic nerve there or not there for this kind of inflammatory condition?
Yeah, it's usually there. There's not.
But I would have expected it to stain more, wouldn't you?
Not necessarily. I mean, it can really vary.
So we have a horizontal and vertical OCT going through the right fovea. The infrared image appears grossly normal, and looking at the B scans themselves, maybe one cell that we can note here. The choroid appears to have a normal, maybe slightly increased, but not too bad thickness. The architecture appears grossly normal here, and looking at the retinal laminations, the inner retina appears intact, and looking at the outer retina, the RPE looks okay, maybe a hint of some ellipsoid zone loss here in the temporal aspect. Not too bad. And then the left eye, where we have most of the pathology here on the infrared image, we can see these reflectivity changes corresponding to the macular lesions we were seeing earlier on. On the B scans, one cell we can note here, the choroid appears to have a relatively normal thickness and architecture to it. You could argue maybe there's some foci of hyperreflectivity within the inner aspect of the choroid itself, and it's really the retinal laminations which really show the drastic change. So the inner retina appears grossly normal here, and looking at the outer retinal layers, the RP layer itself is preserved, though it does seem to have this lumpy nodular appearance, especially centrally with these clumps or clusters that we're seeing here, very distinct foci. And then looking at the ellipsoid zone itself, it appears to be completely gone in the central aspect and just preserved here in the very temporal part of it, which I guess is a little supratemporal.
So what would be your differential diagnosis for this patient?
Yeah, so we have a young patient with evidence of posterior uveitis with predominantly outer retinal involvement in the left eye more than the right. In this particular patient and demographic, I would think about predominantly infectious and inflammatory causes. So amongst the infectious causes, looking at the clinical photos, you could think about, or the color photos, you could think about some entities, but I think the OCT really narrows our diagnosis here. So just broadly speaking, viral retinitis with those whitish appearing lesions, so the OCT doesn't support that. Toxoplasmosis, similar, but again, no full thickness retinal involvement on the OCT. Syphilis is something that I would definitely want to rule out, especially given the outer retinal changes you're seeing on the OCT here. And then TB is something that I would definitely test for in this patient to rule out. Other inflammatory causes I would be thinking about in this case, some of the white dot syndromes, AMPI, it's pretty monofocal for AMPI, but we could have confluent forms appearing similar to this. With that peripapillary involvement, serpiginous also comes to mind, another reason to do the quant gold testing. And within that spectrum, amphigenous would also be on the differential here. Sarcoidosis is something that I would test for in this patient. Just broadly speaking, not based on the OCT, but I guess it would be.
You do a chest X-ray on this patient before you know?
Maybe it's for ruling out TB, I would. But
I think your only three differentials here are syphilis, luetic disease, and spirochetal disease.
That's fair. As the OCT is very, very telling in this case. And just to be broad and thorough, thinking about some, neoplastic causes. Once again, lymphoma, the color photos could look like that, but again, the OCT for the most part does rule it out. And then autoimmune retinopathy could cause outer retinal changes like that. In a young patient might not be the case, but definitely something I'll ask for or inquire in the history.
Excellent. You almost mentioned all the differentials we were thinking of. So I'll provide some more history in regards to our patient. Past ocular history was normal, past months. In terms of past medical history, our patient states intermittent rash over palms 3 weeks prior to presentation. And our patient was non-smoker, no IV drug user, and mentioned unprotected sexual behavior with multiple partners. So what would be your next step?
Yeah, so a lot of hints towards a specific diagnosis here. So I would definitely test for syphilis in this patient, but in anticipation of potentially needing immunosuppression in the future, I would do a CBC, CMP, even a quant gold and a chest X-ray, but the syphilis test is going to be very telling here. I would also definitely do an HIV test on this patient as well.
Excellent. So we got these tests for our patient, and fortunately we didn't test ANA because Dr. Dunn would be angry. The tests were positive. Our patients were positive for RPR and syphilis-specific antibody EIA. So our diagnosis was syphilis. So I'll start describing our patient. In 1988, Souza and Charles Skiffen published a paper in American Journal of Ophthalmology describing 3 young, otherwise healthy patients with unilateral central chororetinitis with severe vision loss. Fluorescein showed leakage under neurosensory retina, and patients were positive for syphilis serology, and they dramatically respond to penicillin treatment. And actually, this was the very first introduction of placoid syphilis to the literature. Yet, it was 1990 when Dr. Don Gass coined the term acute syphilitic posterior placoid chorioretinitis in a paper which was published in Ophthalmology. 6 patients with evidence of secondary syphilis were introduced. They had large placoid yellowish lesions with faded centers at the level of RP in the macula and juxtapapillary area. 5 patients had mucocutaneous lesions, and 3 of 4 patients tested positive for HIV. In a paper published in Retina in 2012, International Syphilis Study Group evaluated 93 eyes with placoid syphilis and reported their characteristics. Nearly 90% of the patients were men. All cases had positive serologic tests, and CSF was tested in half of the patients and was positive in 75% of those who tested. And history of mucocutaneous manifestation was positive in half of the patients. About 40 to 60% of the patients were HIV positive. The pathophysiology of placoid syphilis is not clear, but 2 mechanisms have been postulated. First is disseminated spirochetes entering the choroidal circulation and gain access to outer retina. And the second was inflammatory process and deposition of soluble immune complexes at the level of RP and choriocapillaris and retinal vessels. So one article also suggested thrombosis happening because of anti-beta-2 GPI antibodies, which cause alteration in RP metabolism, disorganization and hyperreflective nodularity of the RP, and impaired photoreceptor function and EZ loss and hyperreflective dots in retina. For the diagnosis, we have non-tripolymal tests and tripolymal tests. The left panel shows the traditional algorithm that have been used, which starts with a non-tripolymal test like RPE, and if they are positive, a tripolymal test will be get from the patient. But nowadays, CDC recommends a reverse sequence testing, which starts with EIA or CIA, which are tripolymal tests, and if those tests comes positive, quantitative RPR or other non-tripolymal tests were get. And if RPR comes positive, the diagnosis of syphilis is confirmed, but in the case RPR comes negative, another tripolymal test like TPPA will get from the patient. And if the second tripolymal test comes positive, the diagnosis is confirmed. Here is the case of bilateral placoid syphilis published in Ophthalmology Retina by our very own Rebecca Suarez and Dr. Don. This patient dramatically responded to treatment after penicillin. IV penicillin. In terms of role of multimodal imaging, I'll describe some features in these patients. Here you can see 4 FAs from 4 different patients. In the fluorescein angiography, we see progressive hypofluorescence, scattered focal hypofluorescence, and leopard spotting appearance in some patients. FAA usually shows increased hyperautofluorescence compatible with borders of the lesion, and the increase in autofluorescence may be due to accumulation of lipofuscin in RPE and in part incomplete phagocytosis of other segments. ICG shows hypofluorescence, and which is due to choriocapillaris hypoperfusion and blockage of choroidal fluorescence by IPV, and extension of lesions in ICG are similar to FA. And finally, OCT in 3 different patients. At presentation, we can see subretinal fluid, disruption of ellipsoid zone, granular hyperreflectivity of RP, but without elevation. But 1 week after presentation, subretinal fluid is usually gone, and we can see irregular thickening of RP in small nodular elevations, which is classic for syphilis, loss of ellipsoid zone, and punctate hyperreflectivity in choroid, which Dr. Shalai mentioned in our patient. In terms of management, we usually check for CNS involvement, which was negative in our patient. However, CDC recommends getting in isolated ocular symptoms with no corneal dysfunction or other neurological abnormalities, positive CT serology and confirmed ocular abnormalities on examination, CSF examination is unnecessary before treatment. Dr. Dunn, do you have any comments on necessity of
10
test?
seconds.
Well, I don't think you have to necessarily do a TAP before you start treatment, but I personally feel it's worth getting a neurologic evaluation, especially if the patient's HIV positive.
Thank you. So back to our patient was admitted and received the treatment. And here you can see 3 weeks later, photos of this patient, and hyperfluorescence has dramatically decreased in this patient in both eyes. And also OCT, which is clearly shows improvement of other retina and RPE, and vision improved to 20/25 in this patient. Thank you so much.